A 54-year-old man presents to his primary care physician for evaluation of poorly controlled hypertension. He has been on multiple antihypertensive medications, including a calcium channel blocker, an ACE inhibitor, and a diuretic, but his blood pressure remains elevated at 170/105 mmHg. He also reports frequent episodes of muscle cramps and generalized weakness over the past few months. His medical history is notable for a 20-year smoking history. On physical examination, there are no focal neurological deficits, and his BMI is 32 kilograms per square meter. Laboratory results show the following. Sodium, 143 milliequivalent/L. Potassium, 3.0 milliequivalent/L. Bicarbonate, 30 milliequivalent/L. Plasma aldosterone concentration, PAC 18 nanogram/dl. Plasma renin activity, PRA 0.2 nanogram/ml/h. Which of the following is the most likely diagnosis? A. Primary hyperaldosteronism. B. Renovascular hypertension. C. Cushing syndrome. D. Pheochromocytoma. E. Little syndrome. Please pause and write your answer in comments. Now let's find the correct answer. Explanation. The correct answer is A. Primary hyperaldosteronism. Primary hyperaldosteronism, CON syndrome, is a common cause of resistant hypertension and is characterized by suppressed renin, elevated aldosterone, and hypokalemia. Patients may present with hypertension that is difficult to control despite the use of multiple antihypertensive agents. Hypokalemia can cause muscle cramps and weakness, as seen in this patient. The key diagnostic feature is an elevated plasma aldosterone concentration, PAC, and suppressed plasma renin activity, PRA, with a PAC/PRA ratio greater than 20, which confirms the diagnosis. B. Renovascular hypertension. This typically presents with resistant hypertension and atherosclerotic disease, but the aldosterone-to-renin ratio is not as elevated as seen in primary hyperaldosteronism. C. Cushing syndrome. Cushing syndrome can cause hypertension and hypokalemia, but it is usually associated with characteristic features such as central obesity, moon facies, and abdominal striae, which are absent here. D. Pheochromocytoma. Pheochromocytoma causes episodic hypertension, headaches, sweating, and palpitations due to catecholamine excess, which are not seen in this case. E. Little syndrome. Little syndrome is a rare genetic cause of hypertension with hypokalemia, but it presents with low aldosterone and renin levels, unlike this patient's elevated aldosterone. Key takeaway: primary hyperaldosteronism is a common and treatable cause of resistant hypertension with hypokalemia. It is diagnosed by finding elevated aldosterone levels and suppressed renin activity. If you loved this video, please like and hit the subscribe button. We will keep uploading new questions on a regular basis.